Teste, teste. Tá me ouvindo, Samuel? Boa noite, pessoal. Estamos fazendo alguns testes antes de começar a nossa reunião de hoje. Vocês já podem participar acredito que a maioria, pelo que estamos vendo aqui, seriam brasileiros, por enquanto. Então, vocês podem já participar do nosso sorteio. Basta compartilhar um stories assistindo ao nosso, colocando a foto assistindo nossa reunião no seu stories e marcando @LACAGE UFSC, que você vai receber um link para cadastro no seu direct, ok? A aula vai ser ministrada em inglês. A gente vai começar em 23 minutos. Evitem lotar o chat somente para dúvidas. Nós teremos um credenciamento inicial, um final. O credenciamento inicial já está na descrição desse vídeo. Talvez em alguns momentos seja interrompida com promoções do YouTube por causa dos patrocinadores de hoje. Então, basta você só assistir o anúncio ou pular o anúncio, que novamente vai se abrir a tela.
So you were in the operating room, Kuri. You are with the scrubs.
Yeah. We just left the operating room. And I was a bit worried about the time, but thanks God we are here now. Thank you.
Laura, another question, Laura. How did you get 4,000 subscription?
Great question.
That's what. Can you hear me well? Because my internet is not so good.
Yes, we can hear you.
Yeah. We have 4,000 subscriptions, but I don't know if all of these people will be really present, because I was thinking about the time, because in Brazil it's 7 o'clock, and in the Eastern is really late. So I think many people that was subscribed to this meeting will actually be sleeping. So 1,000 international people subscribed to this meeting. And
I participated to many webinars, but 4,000, it's a lot of people.
It's normally our audience, it's like 2,000, 3,000 on YouTube.
Oh, really?
Wow.
Yeah. Whoa.
Also, remember, Laura is very young, so she must have an impressive network of people to call on. She knows how to do that.
We have 90 academic colleagues of medical students that are our partners. So we are really happy to stay with them in this meeting and all of them.
Okay.
Hi, Dr. Rafael.
Hi, how are you?
Hello.
Hello, Osmar, Vitor, Dr. Strong.
Hello, it's Vivian.
Rafael. So I didn't recognize you. You took off the bird.
Yes, I mean,
you are shaved now.
I was concerned about the COVID-19, so I was. It's weird. How are you doing that?
Everything fine. You look younger.
Yeah. Sometimes it's a problem. Hi, Kuri. How are you doing?
Hi, Rafael. Hi, Osmar. I'm just seeing you, everyone now. Yeah.
Nice.
So, Dr. Strong, you published a paper for robotic gastrectomy 4 days ago, is it?
I'm so impressed that you've seen it. I haven't seen it online yet. You are all extremely well read. Dr. Correa mentioned earlier that he's seen it also. Thank you.
Oh, yes. Very nice paper. Very nice.
Yes, I read as well. That's really good.
Thank you. Well, it's nothing compared to the Asian series, but I think it's a unique perspective from the West. Both, South America and North America, we have different kinds of patients that we see. So hopefully it will help. Hopefully
it will, definitely.
Thank you.
Oh, 1 minute.
Yeah, 1 minute to go.
Yeah.
Very nice. And which of you are, there are several surgeons and several medical oncologists in the panel. Is that right?
Yes, there is one medical oncologist and 3 surgeons. 4 with me, yes. Mm-hmm.
I see. Okay. Victor, you are the medical oncologist, right? Yes. Yes, and then rest. Okay. All right. That's great. So you're going to ask the smartest questions. I'll be prepared.
So I think we will start right now. Before ask the words to Dr. Danton, I would like to thank all the audience, to our panelists, Dr. Kuri, Dr. Iad, Dr. Rafael Araújo, to our presenters, Dr. Vivi Strong, Dr. Vitor Hugo da Fonseca, and to our moderator, my professor, Dr. Danton Correa, to all the thinking about this event, this meeting. It's really a pleasure to be with these doctors tonight. and be able to talk about what's new in gastric cancer, surgery, robotics, and molecular advance with such a renowned group in Brazil and international. Before passing the talk to Dr. Correa, I would like to ask everyone to get involved in our giveaway that will occur at the end of the meeting in our Instagram account. The prize is 20 white book free accounts, so you can share in your Instagram stories watching our video and tag LACAGE _UFSC so you can participate at this giveaway. Don't forget to like the video and subscribe to our channel so you can look at the new events that will be in the next events. We will have another event about bariatric surgery in the next week. So don't forget to like the video, subscribe to our channel, and we'll have 2 accreditations so you can have you can receive your certificate. One in the beginning, it's already on the chat and the description of this video. You can, but you need to be subscribed to this channel and have registration on the other links. So just wait until the end of this event. We will send another link to the final registration. Okay, Dr. Correa, the world is with you.
Good evening to everyone with us tonight. I am Danton Correa, a surgical oncologist and assistant professor at Federal University of Santa Catarina in South Brazil. This event, Updates in Gastric Cancer, was organized by our surgical league, coordinated by Laura Batista, that you just met, one of our brightest medical students. It's a pleasure to have today with us Dr. Vivian Strong, a worldwide leader in the surgical care of gastric cancer. Dr. Strong graduated at Weill Cornell Medical College, did her general surgery residency at New York Presbyterian Cornell Medical Center, and an advanced laparoscopy surgery fellow also at New York Presbyterian. After her training, she began her surgical practice at Memorial Sloan Kettering in New York, where she still works today in the gastric and mixed tumor service. Dr. Strong has dedicated her entire surgical career to elucidate mechanisms of disease related to gastric cancer, as well as develop better ways to operate on this disease. Her interest in the field vary from minimally invasive surgery and robotic surgery, hereditary gastric cancer, comparisons between Eastern and Western patients, among many others. She has authored more than 100 medical articles, several book chapters, and a book of her own on gastric cancer. She also developed amazing skills in robotic surgery and recently co-edited the SAGE's Atlas on Robotic Surgery. She also just published her personal series on more than 200 patients operated robotically. Least but not least, she's also the principal investigator in a couple of clinical trials ongoing at Memorial at this moment. There's no need to say the great respect that I have for her as a surgeon and as a person. Tonight, she's going to share some of her extensive experience with us, speaking about updates in gastric cancer. She will be followed by Dr. Vitor Hugo Fonseca, a medical oncologist from the AC Camargo Cancer Center in São Paulo. Dr. Fonseca trained at AC Camargo and remains there. He will speak about highlights on gastric cancer from 2020 ASCO conference. After that, some clinical cases will be presented by Dr. Strong and then discussed by our guests, our surgical guests, all of them leading experts on the treatment of gastric cancer in our country. Dr. Osmar Ayagi from Hospital das Clínicas, São Paulo University. Among all his credentials, he did a PhD degree at Tokyo University. Dr. Antônio Cury from Hospital Beneficência Portuguesa de São Paulo. Did his minimally invasive fellow in Louis Pasteur University and Bordeaux University in France. A leading surgeon in our country in the minimally invasive procedures. And Dr. Rafael Araújo, from Escola Paulista de Medicina. Dr. Araújo also trained at Memorial. He was a research fellow there for 2 years. He worked with Dr. Fong and did a hepatobiliary fellow at Paul Bruce in France as well. So we have a great team tonight, and all of them very active in research and care of this disease and considered top stars on this field in Brazil. So I thank you all for being with us tonight, and I'm sure that will be very productive evening to all. Now I leave it with Dr. Strong, who will speak her talk about updates in gastric cancer.
Thank you very much, Dr. Correa. And I, first of all, would like to thank you, Laura, let me thank you for organizing this conference. It's impressive how much you've been able to put together, and to do a virtual conference like this is just wonderful. So I'm honored to be here. And to Dr. Correa, I also have tremendous respect for him. I've known him for many, many years. We were introduced through common association with Dr. Murray Brennan. And he's been a respected colleague and wonderful person. And I thank you for inviting me to be here tonight. So with that, we could start with the presentation. I'm going to share my screen and ask if you can confirm that you see my screen.
Yes, we can see it. It's perfect. So you can now start. Yes.
Perfect. Okay. Thank you. So I was asked to provide some updates in gastric cancer. I know that the audience that we are speaking to includes medical students, residents, as well as primary care physicians and surgeons. So I'd like to cover the spectrum from more general to then more detailed updates in gastric cancer that I hope will be helpful. In terms of overall statistics, it's important to know that globally, over 1 million new cases of gastric cancer occur per year. That makes, according to the World Health Organization, that makes gastric cancer a public health concern. It's the 5th most common cancer worldwide and the 3rd leading cause of cancer deaths. So this is a real problem in the world. As you all know, gastric cancer incidence varies by area of the country. And as you can see in Brazil, the incidence is higher than what we see in the United States. So we know that this is a big problem. Even in the United States, we're finding gastric cancer to be more and more common. If you look at statistics from the US, 2011, yellow bar showing the newly diagnosed cases, and the red bar, the mortality, you can see that over just a few years, these numbers continue to climb and increase. Now 26,000 is the most recent estimate, and still not much progress in terms of improving mortality. So we have a lot of work to do. Why do we have these increases in gastric cancer? What's driving it? So 70% increase in the United States has been found in non-cardiac gastric cancers. So distal gastric cancers, not GE junction. And the highest increases have been in young patients, those 40 years old and under. This was documented in a JAMA article, 2010. And you can see how that incidence has been increasing in the young population. We don't understand exactly why that's the case. There's also been a 7-fold increase in cardiac gastric cancer. As you can see, in all ethnic groups in the United States, GE junction cancers have also been increasing, probably associated with obesity and some other factors. But again, curious and interesting and certainly alarming. We all know that there are many risk factors for developing gastric cancer, and patients will frequently ask, did I do this? What did I do to cause this? There are many factors involved. We know there are genetic factors. For example, the most well-known of which we'll talk about later, hereditary diffuse gastric cancer with the germline CDH1 mutation. Lynch syndrome, FAP, even GAPS, there are different genetic conditions that predispose. Helicobacter pylori, we know that's a carcinogen, which causes 80% of gastric ulcers, and in some cases will increase the risk of gastric cancer for patients that don't aren't treated. So we know that it increases the odds ratio of gastric cancer by almost 6 times within 10 years of having an infection if left untreated. There are a host of other factors which we know about: reflux disease, smoking, alcohol, obesity, chemical exposures. Of note, in the East, oftentimes salty and pickled foods are presumed as etiologic factors because of preserved meats with the N-nitroso compounds. I know that's a commonly documented reason to explain the higher incidence in Asia. I'm not sure that that explains the whole story, because at least the Western diet in America, salty and pickled foods are also pretty common. So I don't think that's the full story. Prior gastric surgery, EBV, also associated with an increased risk of developing gastric cancer, and blood type. So with a bit of overview background, I'd like to go into updates. And I've divided it into 3 main sections: surgical techniques and technology, what's new in that area. Then we'll talk about the new molecular classification system for gastric cancer, which has transformed how we think about this disease as not just one cancer, but several unique types of cancers that need to be individualized in terms of treatment approaches. So what about better selection and surgical techniques? Quite a bit's happened. For the trainees in the audience particularly, what's important to know is who to select for a cancer operation and who to refer to our medical oncology colleagues. We know that positive peritoneal cytology is one of the strongest predictors of survival. A study in Japan, and then a study that we performed at Sloan Kettering back in 2005, looked at the survival after R0 resection based on cytology status. This was a small study, but it was an exploratory study to evaluate whether cytology had an effect on overall survival. And of the patients that had positive cytology at the time of resection, there were no survivors beyond 3 years. That's a pretty remarkable finding. We further went on to evaluate a larger cohort of patients, dividing patients with metastatic disease into cytology positive only, as well as patients that had carcinomatosis, visible peritoneal disease, or other intra-abdominal disease. And although you can see that the patients who had cytology only disease did have an improved median survival 15 months because of lead time bias and disease progression compared to the carcinomatosis, still, even the cytology positive patients end up with a very similar fate, maybe a little longer than 3 years, especially with the adjuvant, with improved chemotherapy, but still disappointing results, which show M1 curves. The results of these studies and others have been instrumental in changing our AGCC and NCCN gastric cancer guidelines. Positive peritoneal cytology is classified by the American Cancer Staging System as M1, or metastatic disease. And the NCCN guidelines panel in the US also has included positive peritoneal cytology as associated with a poor prognosis considered metastatic disease. So this is an important factor in selection criteria. We don't want to offer patients surgery when really they have M1 disease and they need systemic chemo. So what about other technical advances? Laparoscopic gastrectomy for gastric cancer. There have been multiple randomized trials. I have just a few of them listed here, and there are quite a few more than this, that have shown with numerous trials that laparoscopic gastrectomy is a safe, effective, and oncologically equivalent approach to the open approach. And our group looked at a meta-analysis of the highest quality randomized control trial, non-randomized studies and randomized control trials to evaluate this in a meta-analysis, finding that hospital stay and blood loss were significantly lower, no difference in mortality between the two approaches as we would expect. Morbidity, however, was significantly lower with laparoscopic approaches. And that was true in patients where most of the studies that were included here were from Asian countries with healthier patients, lower BMIs. So very interesting. Even more interesting was that in this meta-analysis, minor surgical complications, those associated with wound infection, pneumonia, UTI, were significantly lower in the minimally invasive group, and medical complications as well. So we went on to say, well, with decreased complications, that's certainly an advantage for our patients. Are there other advantages? So a larger study was done several years later looking at open versus laparoscopic gastrectomy, not only in terms of confirming that minor complications were significantly lower and late complications, those happening after 30 days and between 30 days and 6 months were significantly lower. But interestingly, of patients who were candidates for adjuvant chemotherapy, more of those patients ended up being able to get adjuvant chemotherapy after a minimally invasive approach. This could really have an impact on the survival of our patients. In the West, both North and South America, we see far more advanced gastric cancer patients. They need to get on to adjuvant chemo. If we can provide minimally invasive approaches and get them to that needed chemo more quickly and more effectively, that certainly is an advantage. We also have looked at robotic approaches. Robotic gastrectomy, I'm sure that's something that's a hot topic in Brazil as well. We also are very interested in the robotic approach and have embraced that at the Memorial Sloan Kettering Cancer Center. Many of the studies that have been done already, some smaller studies, some larger studies, as you can see, many of them from Asia. And overall, these studies have shown that there is decreased overall morbidity with the robotic compared to open gastrectomy, or equivalent when looking at robotic and laparoscopic approaches, and mortality rate, no difference. We're not hurting our patients. In fact, we might be helping. That's the hope. As someone, I think Dr. Correa already kindly mentioned, a paper that we looked at our own experience of over 220 patients has just come out in the literature. We aimed to see what our robotic experience looked like in a Western cohort. There have been some beautiful studies by my colleagues in Asia, especially in Korea and in Japan, that have looked at robotic gastrectomy and learning curves. But the Western population is certainly a different population, higher BMI, oftentimes patients with more comorbidities. So and patients who get neoadjuvant chemotherapy. So we looked at the learning curve at our center and found that during the first 20 cases, we saw the most significant drop in terms of the time it took to perform the robotic gastrectomy. By the time we reached 60 to 80 cases, whether it was a B2 reconstruction or Roux-en-Y reconstruction, we found the times really plateaued. So the learning curve is significant, but many of the initial learning curve series can really be done and accomplished within the first 20 cases. What was also important for us was to see how we could better select the patients that should have a robotic approach and those who should just be candidates for open surgery. As we all know, in some cases, patients with large tumors, patients with many comorbidities, they're just not appropriate for minimally invasive approaches. But we wanted to have some better guidelines for people who might be starting in centers. So the selection criteria, we looked at the patients that we converted. So out of these 220 patients, every patient that was a candidate for robotic gastrectomy was included, and they were offered a robotic approach. When the patients were offered the approach and we converted, so we had a very low threshold for converting, we looked at the selection criteria and factors that predicted conversion and found that neoadjuvant chemotherapy was much more likely to predict conversion, largely because after neoadjuvant chemotherapy, as you know, it can be difficult to define the borders proximally and distally of tumor after there's been some shrinkage and scarring from the neoadjuvant chemo. We found that tumor size greater than 6 centimeters, also very predictive of conversion. That makes sense. That's in line with other minimally invasive series. And BMI greater than 37. In those cases, most of these patients were converted. I think this also speaks to the fact that with total gastrectomy, especially for patients with a high BMI. It can be very difficult to do the anastomosis. It's different than a bariatric case where you have a pouch of stomach remaining, and making sure that a total gastrectomy is done with no tension between the anastomosis is absolutely critical. And with patients who have a very high BMI, especially men who tend to have more intra-abdominal fat, we have just found that it's safer for these patients to do these operations via an open approach, sometimes requiring retrocolic anastomosis and so forth. And I'll be interested to hear what the other surgeons on the panel have to say about that. Lessons that we learned was that not all cases are appropriate for robotic approaches, and we should particularly exercise caution with diffuse type or signet ring cell type tumors where margins cannot be well visualized, particularly in more advanced tumors, large bulky tumors, and patients. And also patients with neoadjuvant chemotherapy. They may not be the best candidates, especially if you can't visualize margins, and you never lose sight of the fact that the cancer operation takes priority over the technique. So that's important. With the advantages we see here, the shorter learning curve, more precise operation, better visualization, and also image integration. So I think as far as it goes for robotic surgery, this is one of the most interesting points for the future in terms of how we will use image integration, CT scans or MRIs that are overlaid onto our surgical field, and also the possibility for remote access or telesurgery. So I think that's where the field is going in the next years, especially for the students who are on the call. For robotics and technology integration, the robot has a beautiful ability to do intraoperative fluorescent imaging with Firefly. Here's a nice example of the left gastric being transected. You can see a beautiful lymph node packet that is lighting up. This is how we inject robotically or laparoscopically in the peritumoral area. There are different techniques for this. It can be done endoscopically as well the day before. We just tend to do it the day of surgery. And we are experimenting with how this is going to help us to do better lymph node dissections for our patients and more complete dissections with some interesting results. Just fun sort of thoughts for the future to kind of push the envelope. You know, how we could use robotics for telesurgery, and how we could take skilled surgeons who have expertise in a particular field and use that to help patients that are in more remote areas where they may not have access to all of the same surgical specialty skills. This could be an interesting approach. The first transatlantic robotic assisted telesurgery was performed actually in 2001. A patient in Strasbourg, France, and surgeons in New York City who had performed a transatlantic cholecystectomy. So I think there are interesting advantages and thoughts about how we can integrate this kind of technology for the future. So let's go on to new molecular classification. We now have a deeper understanding of the spectrum of gastric cancer as not just one disease, but as several unique types of cancers. We know that there are environmental factors that are important for developing gastric cancer. And you may not know that the Nobel Prize in Physiology or Medicine 2005 was awarded to Barry Marshall and Robin Warren for their discovery that H. pylori was the bacterium causing peptic ulcer disease. They actually infected themselves with H. pylori and then tested to see how long it would take them to develop an ulcer. They proved their point on themselves, and they won the Nobel Prize. We also know that when you do have H. pylori infection and ulcer disease, in some cases, this can also progress to cancer. So that's why this is considered a Class 1 carcinogen by the World Health Organization. We also know about genetic factors, hereditary diffuse gastric cancer being the most important of these. We'll have a case to talk about later tonight in the case presentations that will go into this in more detail. But hereditary diffuse gastric cancer, first described as a familial cancer syndrome in 1964, when 3 families from New Zealand were noted to have a very high incidence of gastric cancer. Dr. Perry Guilford, who Dr. Correa and I know well, in 1998, he discovered the germline mutation in the tumor suppressor gene, CDH1, which encodes EAT cadherin, as the causative factor in this family's hereditary diffuse gastric cancer. So really a landmark discovery. Here's a picture of him. So from these different factors, we hypothesized as a general group that there must be at least 3 different types of diseases encompassing gastric cancer, each with a distinct molecular profile. And this is some early work from a few years ago, in which we looked at the molecular profiling of proximal or GE junction cancers, diffuse cancers, the ones that are more hereditary CDH1 related, and the distal intestinal type cancers, which are more often associated with H. pylori infection. And we found molecular evidence all the way back then, 2011, so almost a decade ago, that showed that there is a distinct molecular profile distinction between these 3 different groups. And they separate nicely on RNA expression signatures. That and that interest in these different types of gastric cancer have been further elaborated on by the very impressive Cancer Genome Atlas project. This was published in Nature 2014 and really changed the whole landscape of how we think about gastric cancer and the different subtypes. We know that there are 4 main classifications based on the TCGA: EBV type gastric cancers, the ones that are associated with PD-L1 overexpression and PIK3CA, so forth. The MSI high or hypermutated, hypermethylated cancers, which we'll talk about later. The genomically stable, these are the toughest ones, the ones associated with signet ring cell cancer or CDH1 mutation, and the chromosomally unstable, which is the most common type of histology. These are the more intestinal type tumors with TP53 mutations. So the classification, this has revolutionized, how we look at gastric cancer. We know that about 9% of patients, at least in this group here, have EBV positive tumors. We know that EBV positive tumors are immunogenic, sort of a virally mediated immunogenic tumor, and the hypermethylation leads to increased cell growth and proliferation. About 22%, and some people have said this is a slight overestimate. In some centers like ours, it's about 10 to 15% of patients have MSI high tumors, also immunogenic tumors with microsatellite hypermethylation. About 20% of patients have genetically silent tumors. These are the ones we need to work on, and we need to call on the young people in the audience here to find some intervention. It's low somatic copy number variation in these tumors. There is upregulation of the angiogenesis pathway. So far, we haven't found really good targets for this type of cancer. And then 50%, the chromosomally unstable, the highly mutated tumors, high somatic copy number variations, P53 and RAS mutations. So this knowledge helps us to develop individualized treatment approaches, and that's really what we have to do. Is it infectious complications? Is it genetic, complications? What is the causative agent? And that has changed how we treat cancer. Previously, we treated all gastric cancers the same way, based on stage, and you're all familiar with the staging system. Stage 1 operation, stage 2 and 3 operation plus minus neoadjuvant or perioperative chemotherapy or radiation therapy, and stage 4 palliative chemo. But this may be an old and archaic way to look at treating patients. We know that immune-based therapy, especially pembrolizumab for MSI high tumors, has been extremely effective for this 20% subset. MSI tumors represent about 20% of gastric cancer cases, as we said, and the high mutation rate allows for a response to immunotherapy or PD-L1 blockade. So this study in the New England Journal of Medicine, just 5 years ago, phase 2 trial looking at PD-L1 blockade for MMR tumors. all these patients with MSI high tumors of all types, whether they were colorectal cancers, GE junction cancers, they all responded to PD-L1 blockade, almost all, which proved the concept that these tumors are unique and require a different approach. Another study published in Science 2017 showed that all types of solid MSI high tumors treated with pembrolizumab had very good chance of response, with an overall response rate of 53% and a clinical response rate of 21%. Based on this study, the FDA for the first time approved an agnostic therapy, basically pembrolizumab for any tumor, which was MSI high. So for the FDA, this was landmark. This was a molecular-based approval, not cancer-based. And we do have a few patients in this study that were GE gastroesophageal cancers. Now studies are looking at gastric cancer and many other cancers. JAMA Oncology 2018 published the KEYNOTE-59 trial. I'm involved in that. 259 patients in 16 countries were enrolled. And this phase 2 trial with advanced or metastatic gastric cancer, the response rate for these gastric cancer patients with pembro for gastric cancer was 15.5% for the PD-L1 positive versus 5% for the PD-L1 negative. We know that MSI high tumors, furthermore, not only respond to immunotherapy, PD-L1 and pembrolizumab, but systemic chemo actually may even harm these patients because it's not effective. So the MAGIC trial in a post hoc analysis looked at patients who had chemotherapy and surgery with MSI negative patients versus MSI positive patients. And you can see that patients who received chemotherapy who had MSI high tumors actually, small numbers, did significantly worse than those patients who just went to surgery. You can see that. So based on this data and other data, we've also looked at the other immunogenic tumors like EBV positive tumors. So both EBV positive and MSI high gastric cancer seem to respond well to pembrolizumab. And you can see this waterfall plot shows that nicely. EBV or MSI high gastric cancer in this study in Nature Medicine showed a 92% response to anti-PD-1 therapy. So again, very exciting changes in how we're treating gastric cancer. At our own institution now, based on this data, when every patient is tested for PD-L1 status. And if a patient has an MSI high tumor, they do not get neoadjuvant chemo, even if it's a locally advanced tumor. They go straight to surgery. And then after surgery, we make decisions about whether additional treatment is needed. There are also ongoing studies looking at pembrolizumab, and I think this is a field that's evolving, and our management of these patients will evolve. But we do know that these patients should not get upfront systemic chemotherapy. They won't respond to it. They need to go straight to surgery. We also know the story about HER2. That's another very effective target for certain subtypes of gastric cancer. The FDA approved trastuzumab for use in HER2 gastric cancer in 2010. We know that HER2 mutations are seen in multiple tumor types. The TOGA trial, for example, in Lancet 2010, these are all fairly recent advances. And adding trastuzumab to chemotherapy, the 3-month increase in survival, there was a 25% improvement in patients who received trastuzumab in addition. So also very interesting. So in summary, for the EBV patients, it looks like they do respond to anti-PD-L1 inhibitors. So helpful to know this about our patients. MSI high, as we talked about, changes upfront therapy. We don't do neoadjuvant chemo for these patients. And that's why we test all of them. For the diffuse tumors, that's where we have trouble and we need help. How do we target these tumors better? We don't have really effective therapies and these patients do poorly. And that's where we need to make some advances. And then the intestinal type tumors, again, the majority of the tumors that respond nicely to systemic chemo. In terms of emerging areas of treatment, We know that genomically stable tumors are the ones that we need more to look at. We don't have good drivers on the DNA level. Perhaps looking at the RNA level or at protein biomarkers, maybe these would be targets and things that we could look for looking towards the future. We also are investigating mutational burden or TMB that might be related to response rates for patients. And there's also a lot of excitement in our country, I'm sure in yours as well, about circulating tumor DNA and how we can use this both as a screening test and also to guide treatment of residual disease. So we have opened a study at our institution looking at patients with circulating tumor DNA and pembrolizumab. Dr. Janjigian, pictured below, is our medical oncologist at Sloan Kettering. She's the chief of GI medical oncology and is the PI of this study. You can see these patients are now currently undergoing randomization after they have surgical resection and treatment. They have ctDNA that's analyzed. If they remain positive, if the ctDNA is positive, they are then randomized into pembrolizumab treatment versus placebo. We expect this study to take a bit more time. We're in the process of accruing, so we don't have data yet, but we will share that with everyone when we do. There are many trials ongoing for immunotherapy for gastric cancer. If you look at clinicaltrials.gov, there probably is an even more recent search than this. More than 20 trials have been listed for gastric cancer combined with immunotherapy. So again, an evolving area that we all need to look at. We're probably going to be incorporating pembrolizumab in some form or one of the other immunotherapies for patients, maybe neoadjuvantly, perhaps adjuvantly. Right now, we're just mostly adjuvant, but I think that will change as results from these great trials are maturing. We do know that there's an interplay between the immune system and cancer. This is an interesting paper published in 2019 looking at tumor infiltrating lymphocytes in gastric cancer subtypes. And it's interesting to see the immunohistochemistry of the tumor infiltrating lymphocytes in the EBV and MSI high tumors. You can see quite a bit of expression of the CD4 and CD8. However, in the intestinal type, less so, and diffuse, silent, almost no immune response for these tumors. Again, supporting the hypothesis of molecular classification. We're looking for unique molecular signatures that could identify high-risk patients. And this is a paper, a small paper, actually it's been published also, that looked at patients who have a genetic signature for early cancer who recur early. So we said, why is it that some patients with T1A or T1B tumors recur when we really normally wouldn't expect that to happen? And we looked at the genomic alterations in these patients and found some interesting findings which are published. So these are small numbers, but hypothesis generating in ways that we could help predict the patients that are at higher risk for recurrence. In terms of treatment for stage 4 patients with exceptional response, that's an area that I'm sure you're seeing as well. We see more and more patients that have exceptional response from the excellent care from our medical oncologists and the improved chemotherapy options. Disease that has stabilized, maybe these would be cases in which we could resect clonal metastases. We know that metastases are often, the resistant metastases develop in other types of cancers like melanoma and so forth. And perhaps it does make sense in certain circumstances to resect metastases. Of course, this should be done under a protocol so that we can study this and have real answers to this question. We know that there are single sites of progressive disease and escape lesions. So we do need new combination therapies to combine the approaches here so that we can incorporate the molecular signature and disease burden to better treat our patients. Now, this is a video. I hope this works. It was very interesting. It was one of our surgical fellows who presented this and kindly allowed me to use this video clip that shows an example of what happens for infection and antibiotic resistance. And I thought this was very interesting. There's a audio that goes with this, and let me know if we don't hear it. But antibiotic different concentrations of antibiotics at 1, 10 times, 100 times, 1,000 times, showing how infections can escape with these clonal metastases to break through the treatments we have. And I think this is a nice parallel to think about conceptually about cancer, gastric cancer and all cancers, how we treat the primary, but there are escapees. We have clonal metastases that escape and outsmart the therapies we have, but we need to outsmart them. So let's see. Oh, I think it works.
First, you see they spread in the area where there's no antibiotic up until the point they can no longer survive.
Can you hear the audio?
Then a mutant appears on the right.
Yes.
It's resistant to the antibiotic. It spreads until it starts to compete with other mutants around it. When these mutants hit the next boundary, they too have to pause and develop new mutations to make it into 10 times as much antibiotic. And then you see the different mutants repeat this at 100.
The image isn't coming through, just the audio.
Oh, just the audio.
11.
Oh, okay. Well, I'm sorry sorry for that. I'll see if we can include this maybe on a link later. But the interesting concept here is that every time the organism reaches an antibiotic dosing, it stops temporarily and then clonal metastases break through. And at every level, it takes time, but they break through. And so I mean to show that as a parallel to what happens in cancer. So it's food for thought for the young and research-oriented people in the audience. We also have some interesting data about the role of the microbiome in gastric cancer. And I think this is fascinating data, looking at how microbial dysbiosis in gastric cancer may contribute to the development of gastric cancer. And you can see that epithelial cells that are broken down by H. pylori, eventually the H. pylori colonization affects these cells, and then other bacterial metabolites can start attacking, develop toxins, and develop cancer. So this is another blossoming area for research right now in terms of the microbiome and how we can modulate that in order to provide better treatments for our patients and better and better health. So in summary, we have more tools and technologies than ever before to help select the best approach for our patients with gastric cancer. And we know that the tumor genomic landscape for gastric cancer is changing rapidly. We need to incorporate molecular signatures and other individualized treatments in order to improve the care for our patients. And the progress will really depend on multimodal characterization and treatments, and will improve by developing combined strategies from all of these areas. So the future is in our hands, and I thank you all for your attention.
Thank you very much, Dr. Strong. It was a great talk. And I believe that this just makes clear that surgery today is not only to know how to cut and how to sew. You need to know much more to take good care of your patients. If you don't like molecular biology and you just are in the wrong field, you are not supposed to be doing surgical oncology. So whoever wants to pursue this career must like this kind of stuff. And it was a great summary. And thank you very much for your time, for preparing this presentation for us.
Thank you.
And it was really great. So now I'm going to invite Dr. Fonseca to give his talk about the highlights in 2020 ASCO. If he can share his screen with us.
Yes, just a moment.
Sure.
Can you see my screen?
Yes.
Perfect. So first of all, I would like to thank Laura and Danton for the invitation. It's a real honor to be with very esteemed and renowned colleagues. So thank you for the invitation. We are going to discuss mainly 4 abstracts, 3 from ASCO 2020 and 1 from the World Congress on GI Cancer. Many of these were in localized disease, so I think it is pretty much the focus of what we are talking tonight. The first study is not actually a study on gastric cancer, but it's a very important study on distal esophageal cancer, which was an attempt to incorporate trastuzumab, which is an anti-HER2 monoclonal antibody for patients with HER2 overexpression tumors. This is the RTOG 1010. So we have a very high rate of HER2 gene overexpression in gastric and in esophageal cancer. That is around 15 to 20% in most of the series. We have data from the metastatic settings showing that the incorporation of anti-HER2 treatment is associated with increased survival in gastric cancer. So they had the idea of incorporating this in the randomized setting. Patients with distal esophageal tumors were randomized to undergo treatment with chemoradiation. Radiation was standard radiation up to 50.4 grays, paclitaxel, carboplatin plus trastuzumab in arm 1, or without the same treatment without trastuzumab in arm 2. Surgery was followed by surgery took place 5 to 8 weeks later, and then patients in arm 1 were scheduled to undergo treatment with trastuzumab until they complete 1 week of treatment. The primary outcome of the study was disease-free survival, and overall survival and pathological complete response rates were secondary objectives. So mainly the study included patients with distal esophageal tumors, and they allowed for involvement of the stomach up to 5 centimeters. All the patients were staged with PET-CT, and many of them were staged with Endoscopic Ultrasound, which is something very important to have patients very well staged before undergoing treatment. So as I mentioned, treatment was conventional dose of radiotherapy. This dose of radiotherapy is higher than the dose that was used in the cross trial, for instance. And for that, they used 1 extra week of chemotherapy, and trastuzumab was used in a very common schedule that we commonly use in clinical practice. So approximately 100 patients were randomized in each arm and analyzed. Analyzing the treatment characteristics, the features of the patients. Most patients had T3 tumors, and at least 60% of them had positive lymph nodes. In terms of toxicity, this is not a very toxic regimen, so the incorporation of trastuzumab did not lead to a significant increase in terms of toxicity. Nevertheless, it was not associated with benefits in terms of disease-free survival or overall survival. In the multivariate analysis, they saw that age and T stage were significantly associated with survival, but not the treatment. Impressively, also there were no differences in terms of pathological complete response. And in something that is very interesting is that we saw that response rates were considered to be very high. Around 25 to 30%, especially if we consider the sub-analysis from the intergroup 0116 trial that showed that HER2 patients, HER2 positive tumors might be somewhat resistant to chemoradiation. So in conclusion, we saw no benefit of adding trastuzumab for patients with HER2 positive esophageal cancer. There are some concerns about this study. Is carboplatin paclitaxel the most effective regimen in this setting? There is some data from a multi-institutional study conducted in the US showing that probably a combination of platinum plus 5-fluorouracil is superior to carboplatin paclitaxel, which is something that was shown in the CLGB trial. And there is some concern regarding the role of HER2 heterogeneity. There are very important papers published very recently regarding this. And there seems to be very important differences in the terms of the effectiveness of the treatment based on the HER2 expression. The second trial is a very important trial, also evaluating the role of personalized medicine in the setting of HER2 positive tumors. This is the FLOT6 Petrarca trial. This is a study from the German group. Randomized patients with a CT24 or patients with a positive clinical lymph nodes and HER2 positive gastric and esophageal gastric cancer to treatment with a standard treatment, which is currently FLOT4 resection and FLOT for additional cycles, or the same treatment incorporating trastuzumab plus pertuzumab. FLOT is a combination of 4 different chemotherapy drugs, 5-fluorouracil, leucovorin, which actually works to increase the activity of the 5-fluorouracil, oxaliplatin, and plus docetaxel for those that are not very used to this kind of chemotherapy. So the study had 2 stages. In the phase 2, they had designed it to have complete pathological response to the primary outcome. And in the second part of it, they tried to evaluate disease-free survival. But the trial was interrupted based on the results of the Jacob trial. The Jacob trial was a phase 3 study that evaluated the combination of pertuzumab plus trastuzumab in the setting of metastatic gastric cancer harboring hyperexpression of HER2. Pertuzumab has shown synergistic effects in the inhibition of the HER2 pathway in breast cancer. So its role in the management of breast cancer is very well established, and they try to evaluate if the same strategy would work in gastric cancer. Unfortunately, they cannot see any statistically significant benefit of adding pertuzumab to chemotherapy plus trastuzumab. Even though we have to notice that it had a borderline statistical significance. And they also saw some differences in terms of progression-free survival, but as the study had a hierarchical outcome design, it did not evaluate if these differences were statistically significant. So it is not very clear if in the metastatic setting, if the pertuzumab is really negative or if there is some sign of activity. In this, going back to the Petrarca, the FLOT6 trial, the primary outcome was a PCR, complete pathological response rate, and R0 resection, disease-free survival, and overall survival were secondary outcomes. The study was a small study with 80 patients, and they had mainly tumors from the gastroesophageal junction, CRIT1 or CRIT2. Only about 30% of the patients had gastric cancer. Most of the tumors were T3 or T4, and most of the tumors were also clinically positive lymph nodes. Most of the patients, at least 50% of the patients, completed all perioperative chemotherapy, which is something good, and it brings better results than what we saw in the original FLOT4 study. One alarming sign was the increased toxicity that we found with the combination. So the incorporation of trastuzumab plus pertuzumab to FLOT increased the rate of grade 3 and 4 diarrhea, which is very important. So grade 3 or 4 diarrhea increased from 5% to 41%, which is very important. It also increased fatigue and leukopenia. There were no differences in terms of R0 resection, and also no differences in terms of mortality associated to the surgery. We could see here improvements in the primary outcome, which was pathological complete response rates. There was an increase from 12 to 35% in pathological complete response rate. There was a statistically significant. We have somewhat immature data regarding disease-free survival. There seems to be some benefit in separation of the curves after 18 months, but these did not reach statistical significance. The same thing happens to the overall survival curves. So this study brings some insights of what we should do in terms of personalizing treatment for patients with gastric cancer, in this case, HER2 positive gastric cancer. Nevertheless, we found increased toxicity, especially diarrhea and leukopenia. And I'm not sure if the results in terms of pathological complete response rate are significant enough for us to change clinical practice at this time. In my institution, we are not changing clinical practice at this time, since we don't have very robust data regarding disease-free survival and overall survival, and there is a very compelling evidence that toxicity is higher. Fortunately, we have other studies that are evaluating the roles of these combinations using trastuzumab or trastuzumab plus pertuzumab. So this is the innovation trial, the ERTC 1203, in which we have 3 different arms. One only with chemotherapy, the other one with chemotherapy plus trastuzumab, and the third one with chemotherapy plus trastuzumab plus pertuzumab. And we believe this study is going to answer the question that was posed by the FLOT6 that unfortunately cannot be properly answered because of the stopping of the accrual in this trial. The third one, it was the FLOT6, which is a study by the same group from the Frankfurt group that evaluated the role of ramucirumab, which is a monoclonal antibody targeting the VEGFR pathway in patients with a localized esophagogastric adenocarcinoma. So it is a very similar study to the previous one, with the exception that patients with a HER2 positive were not selected. So these patients did not select patients based on molecular analysis. So patients underwent regular FLOT, 4 cycles, surgery 4 cycles, or they were randomized to undergo treatment with the same chemotherapy plus ramucirumab, completing up to 1 year of ramucirumab. The primary outcome was the complete pathological complete response rate, the same thing as we saw in the FLOT6 trial. And as secondary efficacy endpoints, we found R0 resection, PFS, and overall survival. So most of the tumors in this study were gastric cancers. Around 50% of them were gastric cancer. Patients had very good performance status. Most of the patients had T3 and positive lymph node disease, and many of them have diffuse type or mixed type gastric cancer. Again, around 50% of the patients completed all perioperative chemotherapy, but there was some concern regarding the toxicity and surgical mortality, especially for patients in the SEWIT type 1 tumors that demanded transthoracic esophagectomy and that were treated with ramucirumab. There was an increased rate of anastomotic leak that led to death. And so they interrupted ramucirumab for this kind of patients. This is actually the only positive outcome that we saw in the study, the rates of R0 resection. We have improved rates with a combination of FLOT plus ramucirumab. When we evaluate toxicity and including hospital postoperative deaths, we see that when in the group of patients that received ramucirumab, there was increased mortality in hospital. But when they excluded patients with SEWIT type 1 disease, mortality rates were similar, demonstrating probably that it is safe to use ramucirumab in patients with SEWIT 2, 3, and in patients with gastric cancer. Again, there was some somewhat increase in the number of patients with negative lymph nodes in the FLOT plus ramucirumab arm. But there were no differences in terms of the primary outcome, which was complete pathological response rate. So this is technically a study that is considered to be a negative one, and studies to come should bear in mind that patients should receive transthoracic esophagectomy. They have a higher risk of anastomotic leak when they're treated with anti-VEGF agents. So this is a graphic that I would like to show you. This in terms of localized setting or in the first line setting, we have a lot of negative trials using anti-VEGFR agents, as opposed to what we found in the advanced settings in second or further lines of treatment, in which we have at least 2 or maybe 3 studies that are considered to be positive. So anti-VEGF agents in early disease do not seem to work as opposed to what we see when we have more advanced disease. And I brought one abstract from the ESMO GI, which what we call World Congress on GI Cancer. Actually, this was a poster presentation at ASCO, but the full presentation only came up at the ESMO GI, and we can find the full paper on the New England Journal of Medicine. This is probably the greatest breakthrough we have witnessed in the treatment of HER2 gastric cancer in the past decade, probably since the TOGA trial. So this is a randomized trial that evaluated trastuzumab deruxtecan in patients with a HER2 positive advanced gastric or gastroesophageal adenocarcinoma. This was a phase 2 trial. For those who are not very used to the idea of ADC, which is antibody drug conjugate, this is a molecular that has some antibody that is targeting a specific marker in the cell. In this case, the HER2 protein that is expressed in the cell membrane. And this is conjugated to a chemotherapy payload that is responsible to the cytotoxic effect of the chemotherapy. We have tried this before in gastric cancer. This is not the first time we tried this, and unfortunately we failed. We used the trastuzumab entamcin, which was a drug that was previously used in breast cancer with a great success. But this not in the Gatsby study, it proved to be a negative trial. This drug failed to show benefits in terms of survival and progression-free survival and overall survival when compared to paclitaxel in the second-line setting. So this was a disappointment. But this molecule is different. It has a somewhat different molecule mechanism of action. It has a higher potency of the payload, high drug to antibody ratio. It has a stable linker, which delivers the chemotherapy only in the lysosomes within the cells. So it has many chemical advantages when we compare to entamcin trastuzumab. So in the Destiny Gastric 1, patients with HER2 expressed in advanced gastric or GE junction tumors with at least 2 prior chemotherapy regimens were randomized to trastuzumab deruxtecan or the physician's choice, which were mainly irinotecan. Most of the patients had intestinal type tumor, which is expected for patients with HER2 gastric cancer. And most of the patients had very strong staining for HER2 in immunohistochemistry. Most of the tumors also were gastric cancers. When you evaluate the primary efficacy outcome, which was overall response rate by independent review, 51% of the patients in trastuzumab deruxtecan arm responded to chemotherapy, as opposed to only 15% for patients that underwent physician's choice for chemotherapy. Again, when we see data for overall survival, there is a strong benefit to use trastuzumab deruxtecan. We have a 4.1 month improvement in overall survival. And the same thing is seen when we evaluate progression-free survival. We have 2 month overall survival benefit, but there is some sign of a plateau at around 25% after 15 months, showing that some of the patients they have a very durable response after treatment with trastuzumab deruxtecan. Regarding toxicity, it seems to be more toxic than the physician's choice of chemotherapy. And there was only one alarming sign of toxicity in this trial, which was interstitial lung disease, which was seen in approximately 10% of the patients that were treated with trastuzumab deruxtecan. So this is something that we have to look when we start treating our patients with this medication. So to conclude, this is a very important study. It proves that for patients with a strong staining for HER2, there is improvements in terms of response rate, disease-free, progression-free survival, and overall survival for patients treated with trastuzumab deruxtecan. And I'm pretty sure this treatment strategy is going to be employed in earlier lines and also in the early disease. So with that, I would like to finish, and again, would like to thank the opportunity.
Thank you very much, Dr. Fonseca. I think that after this talk, we are going to see some clinical cases, but perhaps we can have some comments about your talk. I don't know if Dr. Strong wants to comment something. One thing that calls my attention is that none of these papers presented talk about EBV or microsatellite instability. That it was a main topic in Dr. Strong talk, and seemed to me that it's the most promising area in the systemic treatment of gastric cancer, and I see that they had much more focus on HER2 and not in EBV and microsatellite instability. Am I wrong, or that's or I am correct?
Yeah, the focus at this ASCO was HER2 disease for sure. We had many trials with drugs and new strategies to incorporate new drugs for HER2 disease. Well, HER2 disease is much more common than MSI high and EBV positive disease. So it is easier to make clinical trials in this setting. So this is the reason why I think we have more studies in this. But I think, I think you're right when you say that we should look very, very carefully to patients with MSI high and EBV tumors, especially for patients with localized disease. There's been some debate regarding the most appropriate approach in terms of surgery, upfront surgery, continue neoadjuvant chemotherapy, and I think we're going to discuss this during the night, and I would like to discuss with the panelists this, because this is a very important and emergent issue. But there was nothing very strong. We have some data that is not new from microsatellite instability and immunotherapy. This is something not very new. But I don't think the focus at this ASCO was microsatellite tumors. I would say the focus of the last 2 or 3 ASCOs were microsatellite tumors. This one was the HER2 one.
Any comments, Dr. Strong?
Yeah, I was going to say I really enjoyed your summary, and I think it's very exciting data. I agree with you. I think that there, it shifts in terms of the focus. And I think for the MSI and EBV tumors, there are ongoing trials that are just not robust enough to be ready for presentation. So I think we will see results of this. I know people are avidly working on that area, but this was the year, I guess, for HER2 treatment. I have a question for you, Victor. How will this impact your treatment of these patients? Are you planning to follow this kind of protocol at this point, or how long do you think it will take to incorporate this new strategy into your practice?
That's a very good question, and I think it is controversial. When in our tumor board we kind of discussed this kind of strategy, and after the FLOT6 trial, we had some discussions regarding whether we would start incorporating pertuzumab and trastuzumab in this setting. I just feel like the data is not mature enough for us to say that this should be a standard treatment. The study had only 80 patients, so this is not a very large study. We could find increased toxicity. So one thing is for sure, it increases diarrhea and leukopenia. This is something we know. It looks like it increases pathological response rate, but there was a tricky thing in this analysis, because the pathological complete response rate for FLOT was only 12%. And we know the patients with the HER2 positive disease, they are enriched for intestinal type, and we evaluate pathological complete rates. And in the FLOT4 trial, only for the intestinal subtype was 23%. So 12% seems to be a rather low pathological complete response rate for patients with the HER2 positive disease, in my opinion. And finally, we don't have long-term and robust data regarding progression-free survival and overall survival. So I think it is a little bit maybe immature to start using this in clinical practice. I think we have to wait for the EORTC trial and see if the trial shows at least a similar trend in terms of pathological complete response rate and disease-free survival. Then I think this is going to be more largely incorporated into the clinical practice. But I don't think we are ready for that, at least not yet. I don't know what you think about this.
Yeah. No, I mean, I agree with you. I think it's always difficult to take, take studies like this and then immediately implement them into clinical practice. I mean, FLOT was probably the most striking example of complete and complete acceptance and sudden change of practice. But I think some of these other studies, you're right, they're multifactorial, and they have to be integrated carefully into the data, into the patients, into our patient clinical practice. So I agree with you. Yeah.
All right, so I think that we can move to the clinical cases. So if you can share your screen with us, Dr. Strong, and take a look in this case that you have to present to us.
Oh, sure. All right, can you all see my screen?
Not right now.
Let me try again. Share. Oh, I see. Share screen. So no, that was not the right one. Okay. Okay. Now tell me if you can see it.
Yes.
Mm-hmm.
Yes.
Clinical cases. Good. Okay.
Yes.
So first of all, I was asked to give a few clinical case presentations, which I'm happy to do. What I would like to encourage is all of the surgeons and our medical oncologists who are on the panel here, please feel free to interrupt with comments or questions. I hope to make this an interactive and more informal kind of process. I do have some data to present as well, but I hope to have all of you just intervene with comments and pearls that would help our audience too. So to start, I just wanted to share with you our clinical staging practice. And I know these practices vary from place to place, but at Sloan Kettering, when we see patients with gastric cancer, they usually come in with an endoscopy and biopsy, plus or minus a CAT scan of the chest, abdomen, pelvis. And we categorize off the bat these patients as early stage tumors, middle stage, or late stage. And the treatment strategy for these stages varies. So for those of you who are training in the audience, I think early stage tumors, you usually get a sense based on the endoscopic surveillance. And I'm sure the surgeons on the panel here will also acknowledge that. When you hear about an endoscopy report, a very small tumor, CAT scan does not show any evidence of visualization of the tumor, no lymphadenopathy, you're pretty sure this is an early stage tumor. Those are the cases in which we send the patients for endoscopic ultrasound. And the purpose for that is really threefold. If we find an ultrasonic T1A tumor that meets proper criteria, these are just some of them, small, following Japanese guidelines, less than 2 centimeters, non-ulcerated, no LVI. These are patients that are candidates for endoscopic mucosal resection or ESD. And we have an expert at our center who will do ESD for these patients. Anyone with an ultrasonic T1B or T2 tumor, those patients are not considered candidates for EMR or ESD. Those patients are referred back to us for gastrectomy with D2 lymph node dissection. And for the trainees here, the main reason for this is that the risk of nodal metastases, even for T1B tumors, is high enough that our preference is to do nodal sampling so that we have adequate staging for these patients. If patients are found to have T3 or node positive disease on EUS, then we go to the middle stage. So middle stage tumors, usually, again, you get good signs on the endoscopy report. The GI doctor will describe these as large tumors, poorly distensible. They'll sometimes say 5 centimeter ulcerated tumor. You know that's not going to be an early cancer. Or the CAT scan will show you evidence of wall thickening or perigastric adenopathy. So we know these are middle stage tumors. In that case, we don't do EUS. We go on to complete staging with a PET scan for most patients, a diagnostic lab, and also tumor markers for these patients, as we described earlier. The diagnostic lab is important because we want to rule out late stage disease. If the patients come back as cytologically positive, then we're talking, or metastases based on the PET scan, distant metastases, that would be considered a late stage tumor. If their diagnostic lab is negative at our center, then we divide them into, if it's MSI high tumor, they go directly to gastrectomy, as we talked about. If they're not MSI high tumors, peri-op chemo. And currently, and I know some of the data that Dr. Hugo presented may start to change this, but for right now, if patients have a good functional status, at our center, we'll give them neoadjuvant FLOT. If they have a less good functional status, they're older patients, more frail, then typically our oncologist will recommend neoadjuvant FOLFOX. And for those with poor functional, I see you nodding, so I'm glad to see that sounds like your approach as well. And for patients with poor functional status, those patients sometimes will go directly to gastrectomy. A patient who's very old and frail may not be able to tolerate two types of therapy. So if it's surgery or chemo, we'll usually opt for surgery if the patient can tolerate an operation. And then potentially adjuvant chemo if the patient can tolerate it. For our late stage tumors, again, large tumors, CT findings that say omental nodules, ascites, these are all things that are red flags and that make you say, okay, this is likely a late stage tumor. Those patients will have tumor markers and our medical oncologist will have at it and give them the best treatment that we have available. So that's just a brief overview of how we choose to approach gastric cancer patients in the various stages. Anything that anyone from the panel would like to add at this point? Okay, so we'll go on with our first case. So the first case is a 49-year-old male with abdominal pain for the past 2 years. Underwent an endoscopy, which showed no lesions, H. pylori positive, they had a Prev pack. And then in 2017, the abdominal pain returned, and they had a 0.5 centimeter ulcer noted in the antrum of the stomach, biopsy poorly differentiated adenocarcinoma. A CAT scan, chest, abdomen, pelvis showed no sign of distant metastatic disease. Patient has the following history. So at this point, what would the choices be? How many of you would, I don't know if we have a polling function here, but directly to gastrectomy with lymph node dissection, neoadjuvant FLOT, neoadjuvant chemoradiation, or further workup? So further workup would be recommended here.
Yeah.
Good, I'm glad you agree with that. So endoscopy and EUS was recommended, and small tumor, we weren't quite sure what this would be. Ended up being a T2N0 tumor. You can see it here, a fairly small tumor, but already a T2N0 gastric cancer, which means that the rate of positive lymph node involvement is upward of close to 20%, depending on which study you read, 15 to 20%. So this is, and here you see the endoscopic ultrasound. So in order to know how to evaluate the endoscopic ultrasound, we need to know how accurate is it. And we use endoscopic ultrasound in these cases very much so for pre-treatment risk stratification. We know that EUS is a good test. It accurately stratifies patients into early, what we consider T1, T2, versus advanced T3, T4 tumors for about 85% of patients. And that's based on some data from our center, corroborated by other centers as well. So T staging, it's good. It's not a perfect test. For nodal staging, we found that end stage is accurately determined about 75% of the time. So it's a good test. It's the best test that we have for preoperative risk stratification, but that's the data and those are the numbers. So with that information, next step, PET scan and diagnostic laparoscopy with cytology. Do they go on to get neoadjuvant FLOT? Or would you go to surgery? If so, robotic or open?
Wow.
I would choose surgery, but I would like to also say that there are some centers, especially in Europe, that would do neoadjuvant chemotherapy in this setting, because patients with a clinical T2N0 were included in FLOT4, So some places would would recommend neoadjuvant chemotherapy, but in my center, the clinical T2N0, they are treated with upfront surgery.
Yeah, and I'd be interested to see what some of the surgeons on the call think also, because I agree with you. At our center, these patients go directly to surgery. That's what we'd recommend. But you are right. In some centers in the US also, a T2 tumor will get neoadjuvant chemo, or at one center, neoadjuvant chemoradiation. So there are some variations in treatment here. Anyone else want to comment on that?
I think that if the tumor was more proximal, I would do for neoadjuvant therapy. In this location, if it's a distal gastrectomy, I would proceed to directly to surgery. But if I had to do a total gastrectomy, I would recommend neoadjuvant thought.
With the goal of decreasing, shrinking the size of the tumor, or
no.
The goal?
Yeah. My concern is that this patient may have a complication and never going to have any kind of chemo.
Yes.
So that's my concern. If as my rate of complications is much lower in distal gastrectomies, I would be more confident that this patient at some point would receive the adjuvant chemo. And if I go for a total gastrectomy and the patient has a complication, maybe he never is going to have this chemo, and then I think that I would have caused harm. But I would like to hear Dr. Araújo, Dr. Curi, Dr. Uyagi.
I would like to ask you a question, Dr. Strong. I'm not sure if you also make distinction between distal cancer and proximal cancer in order to indicate neoadjuvant therapy.
Not really. At our center, I mean, I think what Dr. Correa mentions makes very good sense, and I think that's a very good rationale. However, currently at our center, a T2 tumor, in almost all cases, whether it's a GE junction or distal, we would go directly to operation. And I think that's based on our threshold for lymph node positivity. You know, about 15 to 20% chance of lymph node positivity. So if the patient ends up being T2N0 pathologically, they will not be candidates for adjuvant chemo. If they end up being T2N1, they would get adjuvant chemo, and that's, you know, in general. So yeah, so that's our approach. But I do recognize different approaches in different centers.
Yeah, my option here would be number 3, definitely, because I do believe that minimally invasive was the best choice for this patient, because he has such early diagnosis of gastric cancer, but also he has a good performance status, so no issues, no contraindications for minimally invasive surgery. In our context in Brazil, I would put here number 5 as well as laparoscopic distal gastrectomy.
Yeah.
But I mean, the benefits for the patient will be pretty much the same regarding robotic and laparoscopic distal gastrectomy. So minimally invasive surgery will be my choice, and definitely D2 lymphadenectomy.
That's great. So that's what I would choose also, but either would be an appropriate option, robotic or laparoscopic or open. In terms of which one to choose, we do have good data that demonstrates from randomized prospective trials that there is a similar overall in cancer-specific survival. You should all know about it, for the audience, the Class 01 randomized control trial, 1,400 patients, where overall in cancer-specific survival rates between patients with LAP and open distal gastrectomy was the same. Class 02, randomized control trial of over 1,000 patients, looking at patients with locally advanced gastric cancer. And this is important because initial studies just looked at early stage cancers, but now Class 2, and there's also a Chinese study, Class also, but with a C, Class 01 and Class 02, that has looked at the same 2 questions with similar outcomes. And we do know the benefits, as as Dr. Rujo was mentioning, in terms of lower complications, faster recovery, and less pain. So it's a nice option if you have the expertise at your center. So in terms of what kind of, the patient underwent a robotic subtotal gastrectomy with D2 lymph node dissection. Do you want to do an intraoperative frozen section? And if so, do you do a frozen section of the proximal, distal margin, both, or neither?
It was an intestinal type. I can't recall.
Yes, yes.
Intestinal type.
Poorly differentiated. Yeah.
Yeah. First of all,
any frozen section.
You would not.
I wouldn't. It's intestinal type, right?
Poorly differentiated intestinal type.
Yeah.
We'll do both.
You would do both?
Yeah.
Yeah, me too. Me too. I would do. And I think something. Oh, sorry. Please, Dr. Osmar.
Oh, I think if you have any doubt, you would ask for frozen tissue, frozen section. But if you don't, I think you are authorized not doing. But you have to be sure that the confidence that the edge is fine.
Yeah. Go ahead, please.
Sorry, I'm sorry, Dr. Strong. I think we can do both. We can do the frozen section or not. But something important on this case is that we are in doubt about lymph node 6 compromised. We should remove the 14V lymph node in this case. That's very important to say. And also something very important that you said, I think we can discuss after, is that we need to have a very good CT scan with a gastric protocol. We need to have a very good distension of the gastric cavity to understand T1 and T2 tumors also. Yeah. But I use the frozen section much more for the upper part than the distal.
Yeah. So like you, I agree. I typically, my personal practice, I typically will get a frozen section of the proximal margin. I rarely get a frozen section of the distal margin unless it's a linitis kind of case, a signet ring. And I know that would be a different case and probably different answers from all of you. It's fascinating that there are many different approaches to how to handle this. So I typically, is intraoperative frozen section necessary? Typically, I'll go up to pathology with the specimen. I actually look at the tumor and we open the specimen so that I can really see where the tumor ends. Again, for poorly differentiated tumors, I generally advocate a proximal frozen margin because of the submucosal spread potential for poorly differentiated tumors. For moderate and well-differentiated, those are cases where I typically still get a proximal margin, but I would be less vigilant about that. Here's a picture of this particular tumor, and looks like it's a nice margin. Here's an example of us cutting the frozen section, getting both layers of the mucosa, and this is an example of another case which will not be a negative margin. You can see the tumor here infiltrating the wall of the stomach, even though you don't see it quite as much on the mucosal side. But I just thought it's an interesting instructional kind of picture. So we do have data about intraoperative frozen sections, which I wanted to share. We know that about 12% of frozen sections end up being positive in one study that was published from Annals of Surgical Oncology. The signet ring cells were present in 83% of false negative readings. So signet ring cells or diffuse type tumors, those are the ones where you do want to get a frozen section, but you have a higher likelihood of your pathologist giving you a false negative reading. And out of 3,000 patients in another study, the prevalence of frozen section negative results was of false negative results was 1.7% with an accuracy of 98.1%. And the false negative intraoperative rate was higher for patients with the diffuse signet ring cell tumors compared to those without. So I think those are sort of take-home messages. And then each of, everyone in practice will develop their own system and their own, preferences in terms of frozen sections, when to use it, when not to use it. But again, personally, I generally do proximal. Signet ring cell tumors, those are particularly complicated and difficult tumors, and ones that the audience should have caution with. In terms of the reconstruction, robotic subtotal gastric.
It was positive, the margin, or not?
It was, well, you'll see.
Right.
Okay.
Just one comment before you change for the type of surgery.
Yeah.
My point is, as soon as we move it to minimally invasive surgery for gastric cancer or maybe colon cancer, so the point is to feel, to use my hands to touch and estimated the margin, it decreased. And moving again to robotic surgery, it's even worse because we have to develop haptic skills to get it. So that's the why I'm using more and more frozen section in robotic resections, exactly to trying to to increase my to be sure that I'm doing the correct resection. That's why perhaps in open surgery I would say, okay, that's the tumor, here it's good enough, that's okay, that's fine. But as soon as, especially in the stomach, we don't have the tattoo, using tattoo usually as we use in colon. So, I mean, I think that's good to always do the frozen section. Perhaps the distal I would make it in this case, but the proximal for sure I would do it, and that's my concern exactly because I can feel it well.
I think that's a great point. And with minimally invasive surgery, especially robotics, the haptic feedback is lost. And so actually in the series that we just published, one of the reasons for conversions was that lack of haptic feedback, where you just know that if you can feel it, you might be able to spare some stomach. And I think all of us will agree that anytime you can do a subtotal, that's better than doing a total for the patient. So if there's any question of that, then conversions to actually palpate is correct. I agree with you 100%.
Dr. Strong.
Go ahead.
Dr. Strong, before speaking about reconstruction, do you use some oval suture in the duodenal stem? I mean, I thought you doing something with SynGuard, but I'm not sure if you do in all cases or you cut. I don't have conflict of interest also, but I would like to listen to your opinion.
Yeah, thank you. I also do not have conflict of interest. I have no stocks with SynGuard or any relation, but I do use SynGuard pretty frequently. Actually, in all of my cases, whether they're open or minimally invasive, on the duodenum, and it serves two purposes. It's decreased bleeding. There's some, we don't have a randomized study to prove it, but I think it may help reinforce the staple line and decrease risk of leak. And also it prevents the need for having to oversew with another layer, which I think can sometimes be not as easy as one would think. It's easy to tear a little bit, and so either approach is fine. Another surgeon at my center typically will oversew the duodenum in his open cases, and that works for him. But the SynGuard is what I use on all of my cases for the duodenum, and I've had very nice success with that. So, yeah.
Dr. Strong, I think that I can point two important things here. Let's think that this lesion could pass through the pylorus and take the duodenum. Sometimes it happens. In frozen section, usually we can't say for sure that this is occurring. It changes two things, in my opinion. The first thing is that if the lesion is coming through to the duodenum, we should take the lymph node 13. It's considered as a D2 local regional lymph node. Another thing that if the patient have a tumor or some islets in the duodenum, for sure, maybe he will receive radiotherapy after surgery, after some time of surgery. So I will be concerned for frozen section much more for prepyloric lesions than from antrum.
Yeah, no, I agree. I think that you make a good point. And of course, these are just general guidelines, but every case has to be, the clinical judgment has to be used. Just to go on so we can get through as many cases as possible, in terms of reconstruction, there's quite a bit of debate. Some advocate the Billroth-1, especially in Asia, South Korea. Dr. Han Kwang-Young is an expert at an interesting Billroth-1 reconstruction. I think it's called the tornado approach, which is beautiful. There's the Billroth-2 reconstruction and Roux-en-Y reconstruction. And we do have data. Many people question what kind of reconstruction is the best. We do know that there is more bile reflux with the Billroth-1 and 2 reconstruction. However, Roux limb stasis syndrome is a real consideration when performing a Roux-en-Y reconstruction. And also with the Roux-en-Y reconstruction, internal hernia risks through the Peterson space is also a risk, which is generally not a risk with B2. We have not had, I think in all the years of our gastric database, we've had one internal hernia from a B2 reconstruction. And it's the internal hernias it's the Roux-en-Y that really cause internal hernias, which can be life-threatening if not recognized quickly. Also, anastomotic gastric cancer risk from bile and inflammation for B2 reconstructions. That can sometimes happen, as you all know, and I'm sure have seen, 20 or 30 years after a distal gastrectomy and a B2 reconstruction. Well, in fact, I just saw a patient like this on Tuesday, and it's an additional problem for patients to think about, especially if you're doing a distal gastrectomy in a very young patient, one under 40. Randomized controlled trials, which have looked at Billroth-2 versus Roux-en-Y subtotal gastrectomy. Nice study from 2018 with almost 200 patients. In that study, they found no difference in morbidity or mortality with the two approaches, no differences in GI symptom score or nutrition by the 1 year mark, and less endoscopic gastritis in the Roux group. So fairly comparable. The Chinese Southern Gastric Cancer Trial, which is currently accruing, is actually performing a multi-center prospective phase 3 trial of 800 patients that will directly head-to-head compare the efficacy of Roux-en-Y versus Billroth-2 for distal gastrectomy for gastric cancer. So so we could break for a moment and talk about reconstruction, or we can just go on with the case, whichever you prefer.
Go on.
I will say in general, if we, in my practice, if I'm leaving at least half of the stomach, if I'm at the incisor or lower in terms of my resection, I oftentimes will consider a Billroth-2 reconstruction unless it's an extremely young patient. Otherwise, Roux-en-Y reconstruction if I'm taking half or a little bit more than half of the stomach to avoid some of these problems. So that's my general practice.
I think that,
go ahead.
Please, Dr. Yagi.
Yeah, we do the same. If we do a distal gastrectomy and we do Billroth-1, but if we do subtotal gastrectomy, we prefer to do Roux-en-Y.
For the subtotal, yeah.
Yeah,
that's great.
But this patient is young.
Yeah,
that's the point.
That's true.
So
yes.
I am assuming that you choose Roux-en-Y.
There we go. Look at that. So the intraoperative frozen section of the proximal margin, as Anton was curious about, was negative. So we then proceeded with Roux-en-Y reconstruction. Uncomplicated postoperative course, the patient was discharged post-op day 5. And since it's a case presentation, of course, it's not going to be straightforward. The pathology ended up revealing a pathologic T4A-N1 tumor, 3 of 26 positive lymph nodes, poorly differentiated adenocarcinoma with signet ring cells, Lauren's diffuse type, which was not known on the pre-op biopsy. It can be misleading. And the final proximal margin, microscopically positive for cancer, although the frozen was negative. Yeah, so everyone on the panel is looking at this. This is not an ideal outcome. Again, poorly differentiated tumor. There was extension that was not recognized even on frozen section. So now what do we do? Positive margin. Again, red flag for poorly differentiated or signet ring cell tumors. So it's a PT4N1 tumor, positive proximal margin in a 49-year-old male. What would your thoughts be here? Be curious to hear from the panel what they would do next.
I would discuss with the pathology group and try to guess if the margin was very how can I say, the positive margin was big or not. If it was very small, I think I would do something like not surgical procedure, but if you have a bulky tumor in the edge, I think I would perform the surgery again. But we have many times we had such a discussion here, and if you have any doubt, we do total gastrectomy. We always consider about having or not frozen section, but we have to sleep with how can I say? We have to think that we did safely the distal, the proximal margin.
Yeah. So just in the interest of time, the point of basically of this case is when should we operate on a microscopically positive margin? What is the association of the positive margin with survival? Those are the questions to ask. What is the anastomotic recurrence rate in patients with microscopically positive margins? And does TNN factor into the decision? So those are the questions that we need to ask. The data that we have is helpful. Dr. Kim and Brennan in 1999, way back then, looked at 47 of 600 patients, over 600 patients with an R1 resection, finding, as we all know, that an R1 resection was predictive of poor survival for the entire cohort. However, they also looked at an R1 prediction, R1 positive margin rate, and found that it was not predictive of overall survival if more than 5 lymph nodes were positive. So in other words, the predominant factor, when you had 5 or more positive lymph nodes, was the systemic recurrence, and a microscopically positive margin actually didn't affect overall outcome of the patient. Whereas if there were less than 5 positive nodes, then the positive margin actually was significant and important. So this was a very helpful study for us in terms of stratifying in these rare situations what to do with these patients. In 2013, an update was done looking at over 2,000 patients. We found 4.5% of the patients had positive margins, and 108 of those patients underwent curative intent resection of those margins. We found that margin status was an independent predictor of survival, with 3, so even less now, 3 or less positive lymph nodes for T1, T2 disease, but not in patients with more than 3 positive lymph nodes or with more advanced T3 or T4 disease. So, and local recurrence at the site occurred in 16% of patients with a positive margin. So in some cases, perhaps the pathologist, as Dr. Yagi was mentioning, perhaps it was just microscopically a couple cells, and perhaps it was a sampling error. You always have to consider the possibility that you may re-resect and have no additional cancer in that specimen. But you can see that in these cases, this helps us to stratify when we should do an additional surgery or not. So R0 better than R1, R2, about a 16 to 24% local recurrence rate at the anastomosis, and more than 3 lymph nodes, or T3, T4, makes positive margins less relevant in terms of decisions to reoperate. So hopefully the whole panel agrees with that. So the patient recovered over the following 6 weeks. We did a completion total gastrectomy with Roux-en-Y reconstruction. Final path, there was no residual carcinoma found in the stomach. Yeah, and the patient did go on to receive adjuvant systemic chemo. You could say that he might have been a candidate not to have additional surgery, but again, I think this speaks to the fact that in some cases, you see the patient sitting in your room and in your chair, and after a discussion, you sometimes do things that don't completely correlate with the data. He was sort of a borderline case, but here that was this case. So take-home points from this first case: poorly differentiated or signet ring cell type tumors. Be very careful and be suspicious of more extensive involvement. I think that checking intraoperative, at least proximal margins, is critical. You've heard from the panel that some people think both, some people think in certain cases neither. There is some controversy there. And in terms of positive margins, the number of lymph nodes and the the stage of the disease should help you to make a decision about whether or not reoperation makes sense for your patient. So any comments on that before we go to another case?
I think that there is a paper from Memorial. I believe that most probably you are one of the authors that shows that for minimally invasive procedures, the proximal margin has a higher degree of positivity compared to open gastrectomies, and this is much more so in proximal cancers. I don't know if I'm sure. Is that correct?
Yeah, well, we found that in some of our initial laparoscopic experience. Now with our robotic gastrectomies and with better stratification, as I'm trying to remember who had said that comment. Raphael, I believe, had mentioned that the inability to palpate the tumor, that's an important factor. And I think with experience minimally invasively, you come to the conclusions that Dr. Rujo has talked to us about, which in some cases you just need to palpate the tumor in order to be sure that you have a negative margin. And personally for us, a conversion is not considered a failure. It's considered a sign of wisdom when we think that we can do a better operation open. And I think that's important. Some minimally invasive surgeons feel so strongly about completing the operation that way that they lose sight of the fact that the cancer is what's the most important fact. So I feel, that's important.
Right.
Well, that was a tough case, exactly because you did everything correctly before. And the impression for early disease initial, and then you find like this is really unexpected. But I do agree totally, especially because it's a young patient with a disease that's worse than we expected regarding both extension T, but also the nodal extension of disease as well. So since that you have to offer the better approach, surgical approach as possible, and for a young patient that have to totalize a gastrectomy, probably he did well, and you show it. So I would offer it, even with the data showing that perhaps you can offer a control with radiation therapy, or just I'm not enthusiastic with radiation therapy, especially after artists and critics and all those papers, even but I mean I totally agree with your decision to totalize this gastrectomy.
Thank you.
And
So,
if the patient had, sorry, please, Dr. Yagi.
Oh, sorry, Dr. Dr. Strong, so would you consider to use intraoperative endoscopy for looking the margins, or would you not?
Yeah, I mean, I use endoscopy in every one of my cases. I always have a gastroscope in the OR with me, and I will scope the patient usually before beginning the operation. But I think in some cases with these tumors that are submucosal in terms of their spread, they can be very misleading. I mean, we saw the picture of that particular tumor. It looked well defined, but I think that's just why the poorly differentiated and signet ring or diffuse type tumors are the ones that we all are the most cautious of, because we know they can trick us. And in this case, it did. Yeah. So, yeah.
No, and for sure, this case was the best choice for do by robotics, in my opinion, because he didn't receive neoadjuvant therapy, and it was a T2 and 0.
Yeah,
so I totally agree.
Yeah. So we could do one other case. I don't know if we have time for 2 more, but what do you think, Danton? Do you think we should do the CDH1 case? Maybe that would be more interesting than the other case, or?
It's up to you. I think that both cases are interesting. I believe that perhaps the CDH1 is very nice too.
Yeah. So let me just skip ahead to that, and we'll see how much time we have.
All right.
Let's see where we are. This is not this case. There we go. So the next case, just to switch gears a little bit to CDH1 mutation, is a 50-year-old male who presents to the office, as many of these patients do, with a genetic test report saying, I have just tested positive for a germline pathogenic CDH1 mutation. And we're seeing more and more patients like this at our center. We see quite a few every month. And this patient not only has the germ mutation, but germline mutation, but he comes in with a family history, which is why he was tested. His brother died the year prior at the age of 51 of metastatic gastric cancer. And that's what prompted the testing, because everyone said, wait a second, our mother also had gastric cancer, and she died of that, as well as lobular breast cancer, which she had survived, but she died at the age of 52. So here's a man, he's 50, and comes to the office with this history. He's also a physician, well-informed, has 2 children, and wants to know what we think we should do. So he undergoes endoscopies, and actually over several months, he had come with already 1 endoscopy that was normal, then had a second endoscopy several months later, multiple biopsies, all negative for cancer. So the question here is, what would you do with this patient? CDH1 mutation, convincing family history. Would you continue surveillance and just say, we'll surveil you closely with endoscopy, or say, no, it's time for total gastrectomy?
Recommend gastrectomy, in my opinion.
Good.
Surgery, yeah.
Yes. I think that, this one is meant to be pretty straightforward. What's important for the audience also to know is that surveillance endoscopy, that's what all patients want. Nobody wants to have their stomach removed, especially not prophylactically. And a total gastrectomy is a big undertaking. So patients will always ask this question, why can't we do surveillance endoscopy for CDH1 mutation? There's some good studies that have address this question, but they're all small and we do need more data. One of them was University of Cambridge 2018, published looking at 54 patients with germline CDH1 mutation. 15 patients, most of them went to gastrectomy, but 15 said, no, I'm going to have surveillance endoscopy. During the course of surveillance, 1 patient developed an invasive signet ring cell cancer after 3.5 years of surveillance, a pathologic T4N1 tumor, even under surveillance, then underwent total gastrectomy and chemotherapy. The other 14 patients who underwent surveillance endoscopy, 4 of them during subsequent endoscopies were found to have signet ring cell cancer and had total gastrectomy. 10 of the patients are still undergoing endoscopies, The follow-up in this paper is rather short, so we need longer follow-up to know what's going to happen to them. Another study, Mass General, a series published in 2019 of 42 CDH1 patients. 32 underwent total gastrectomy immediately. 30 of the 32 had signet ring cell cancer. 10 in this group said we're undergoing surveillance. One patient developed a T3N0 tumor after 9 years of surveillance. And he underwent total gastrectomy, but did require chemotherapy. Apparently is still doing well at the last follow-up from this paper. And 9 are still undergoing endoscopy. So the point here is the numbers are small for us to actually put numbers on this, but surveillance is not necessarily an adequate way for us to make sure we can catch these tumors in time. And that's an important point for patients to understand. You're taking a risk by undergoing surveillance endoscopy. If you look at signet ring cell cancer detection rates from EGD, we know that they're very low. This is a summary graph that was put together by one of my fellows, Dr. Vos, and it shows that in a series of different studies, the detection rate of signet ring cell cancer, these small nests at endoscopy, was only about 15%. And of the patients who underwent surgery, 91% of them were found to have signet ring cell cancer in the final specimen. And the reason is it's very hard to find these spots. You need a very talented endoscopist who has experience in finding these lesions. This is one case in which you just barely appreciate this pale patch right here that was biopsied and showed signet ring cell cancer. This is not from this particular patient. Here's another one with NBI or confocal microscopy in which you can see some alteration in the microvasculature or sort of the swirling of the gastric mucosa, which led this GI person to biopsy this area with a small focus of signet ring cell cancer. So these are very subtle, hard to find. So we all we all decided that gastrectomy is the right thing to do here. Whether we do total versus subtotal, laparoscopic or open, I think we'll just jump ahead here, and obviously total gastrectomy is what's required. Laparoscopic or open are appropriate approaches. And in terms of hereditary diffuse gastric cancer, it's interesting that 1964 was the first description of the Maori families. We already saw this earlier, but Dr. Perry Guilford, who discovered that families carry this germline mutation in the tumor suppressor gene. And we know that E-cadherin is a transmembrane glycoprotein that mediates calcium-dependent cell-cell adhesion, and that's important for cell polarity and epithelial differentiation. And germline loss of this E-cadherin expression, which is what happens, increases the lifetime risk of developing diffuse gastric cancer and lobular breast cancer. The International Gastric Cancer Linkage Consortium, which was most recently held a few years ago, established criteria for testing. If you see a patient with a diffuse or signet ring cell gastric cancer diagnosed under the age of 40, they should have testing. Or if there are 2 more gastric cancer cases in the family, regardless of age, at least one confirmed diffuse gastric cancer, or a personal or family history of diffuse gastric cancer and lobular breast cancer with 1 diagnosed under the age of 50. So these are current recommendations. The rationale for performing gastrectomy in the absence of endoscopies that reveal cancer is that in these cases, patients likely have a dormant period in which adenocarcinoma does not spread or become invasive, a very low proliferative index. We don't know if this dormant period lasts for years. Does it develop at a certain point in a patient's life? We don't know, but there is this dormant period. And some second hit is involved in order to develop invasive cancer. We also know that patients who develop invasive or symptomatic diffuse gastric cancer have a dismal prognosis. I know that the incidence of signet ring in South America is quite high, as it is in the US, and very few patients have potentially curable disease since it's very aggressive, with about a 30% 5-year survival rate at best. We know that the risk of developing diffuse gastric cancer for someone with the germline CDH1 mutation by the age of 80 is 70% for men and 56% for women. So that's a high risk. and that women have an additional 42% risk of developing lobular breast cancer by the age of 80. Average age of onset of invasive gastric cancer is 38. These are general guidelines, but having said that, it's very important, and anyone in the audience should, in the panel should please comment, that the decision on when to operate on these patients depends really on the family history. So in some cases, patients, the youngest person in the family is, maybe 30 when they've had invasive gastric cancer, and that guides your decision-making and timing for these patients, because that's one of the main issues. Just last week, a couple weeks ago, I operated on an 18-year-old girl who has germline CDH1 mutation and a significant family history. When she saw me, I at first was planning to tell her, wait, you're not going to have, come back and see me in a few years. However, then she told me that her first cousin developed invasive gastric cancer at the age of 17. So yeah, so that changed. I mean, that's quite an exceptional case, but that definitely guided our decision to go ahead and offer her the gastrectomy at this age. So indications and timing: patients with the mutation and family history should be offered prophylactic gastrectomy. The timing, as we discussed, that is open to interpretation that has to be carefully managed, knowing these statistics. And as soon as you tell patients that they need a prophylactic total gastrectomy, that's the question everyone asks. Can I live without my stomach? It's a big lifestyle change for patients. And this patient in particular, he underwent laparoscopic total gastrectomy with reconstruction and an omega pouch. We can talk about that. I did not place any drains or nasogastric tube, but the patient clinically did well. So we did not do a gastrograph and swallow study. These are some postoperative management things that we could discuss if you want. And the final pathology in this patient's case, 22 distinct sites of T1A signet ring cell gastric cancer, all T1A, 0 of 23 lymph nodes positive, and proximal margin showing benign squamous mucosa, and the distal margin showing benign duodenal mucosa. So in this case, always a proximal and distal margin is what I do to confirm that all the at-risk gastric cancer, gastric mucosa has been removed. Here's an example from this patient. You can see some slight disruption and signet ring cell, one foci right here. And the analysis of these stomachs is a labor of love. Our pathologist, Dr. Laura Tang, has devoted much of her career to carefully evaluating, documenting the tumor sites for these patients. This is an example of one patient where every single red box here, rectangle, represents a distinct site of T1A gastric cancer that was discovered in this stomach. So the advantages, it's a curative procedure which eliminates the need for surveillance. We know that endoscopy can miss occult lesions, but the disadvantages, of course, there are short-term operative risks, the morbidity leak, abscess stricture, and mortality for total gastrectomy as well, which needs to be considered, as well as long-term nutritional issues, such as altered oral intake and weight loss. So when patients say, can I live without my stomach? This was a nice article that was featured in one of our American newspapers, the Wall Street Journal, a few months ago, in March of 2018, actually. And they documented and discussed how patients with this mutation, how they do without a stomach. And you see in this article, they show this family that has been plagued by CDH1 mutation. All 5 people pictured here have no stomach, and they all look pretty normal. This is a father-daughter duo that I operated on. The father went first, and then the daughter about a year later. They're both doing extremely well. There are some altered intake and nutritional considerations, but you can see people can go on to have a normal, good life. So we reported our experience, our initial experience with this, and in 41 patients. And there are some other details to this paper, but mostly what I wanted to highlight is post-operative outcomes and weight loss, because patients want to know what will happen. So in this paper, we looked at pre-op BMI and the corresponding post-op BMI for each patient. The post-op BMI was at least 6 months or longer after surgery. And you can see for these 41 patients, almost all of them maintained a normal or even in some cases overweight BMI after undergoing total gastrectomy, 6 months or more after surgery. And very, very few patients dipped below to what we would call underweight. So with the majority of the weight loss being in the first few months up to about 6 months and then stabilizing thereafter. So patients can have good responses. And in terms of quality of life, we provided some questionnaires and asked patients how they felt. 85% of patients reported having outcomes as or better than they expected. And 40% of patients did say that they had dietary modifications, including avoiding carbonated drinks, not being able to eat large amounts of sweets, especially concentrated sweets, as you all will comment, I'm sure that's a common, an issue for patients, and certain types of bread. And the one good thing was that all patients who were working full-time jobs before surgery did all return to full-time work once they had gone through the recovery period. So there is hope and, you know, some good outcomes for patients who do have to undergo this, you know, life-changing operation. There is some more data that's coming out that I wanted to be able to present. Unfortunately, the journal has embargoed the data. They said we can say the title and this paper will come out in early September. But in this update, we look at data on the rate of signet ring cell cancer in specimens in terms of pathogenic and likely pathogenic mutations versus VUS. Really, these are the patients that are at risk, I can tell you that. And the VUS, we do not offer total gastrectomy. And we also look at, is there a definable risk for patients who have this mutation, but no family history? And I don't know what's happening in Brazil, but I'd love to hear what you are all doing. Recently, in the United States, a mandate was issued, or recommendation was issued, that any patient with breast cancer has been recommended to undergo genetic testing. And that has just opened up a Pandora's box for us in terms of patients who were tested, presumably looking for BRCA mutations, and they have a pathogenic CDH1 mutation with absolutely no family history of gastric cancer, or perhaps not even lobular breast cancer. And they're coming into our offices and asking us what to do about it. Should they have total gastrectomy or not? So there's some data in this paper that will address the fact that there is an actual real risk for invasive cancer for these patients, even without a family history, although that risk is significantly lower than for patients with a family history. So hopefully you'll all tune in and be able to see that data when it comes out. So these are some of the key principles that we reviewed. I'd love to hear what the panelists here have to say and what your experience is with this mutation in Brazil. Is it a big problem, or how do you approach this?
Sometimes we see patients where if you have a pathological mutation, okay, I think it's well indicated. But sometimes we don't know exactly if it's a pathogenical or it's unknown pathogenicity. So in these cases, it's very difficult to talk to patients. And the last year, as you told, we found a publication with patients without a family history. And this made us more confused because we don't know when to indicate surgery, even though they have pathological mutation in their family.
I think as you said, most part of the times the patient and the family decides to operate. The experience that they had with their family. I had a 32 female patient 2 years ago that she had 4 generations of gastric cancer in her family, and she asked for the surgery. So I totally agree with you. It happens frequently, and but it's difficult to decide, like Dr. Osmar said.
I have a question. If you have a young patient below 40 with no family history, and is a tumor in a location where you could perform a distal gastrectomy, not a total gastrectomy, would you test her or him to see if it has the mutation to proceed then to a total gastrectomy?
That's such a great question, and yes, actually, what we're doing at our center is we have a great genetics department. Our geneticists are just really wonderful, and they work closely with us. When we see anyone who has a gastric cancer under the age of 40, we do consult with our medical geneticist, because anyone under the age of 40, you want, even if it's not a diffuse type tumor, an intestinal type, there are some other mutations, and sometimes our geneticist will uncover that. But to answer your question, for somebody under 40, particularly with a cancer, a diffuse cancer in the lower part of the stomach, where it would make the difference between a subtotal versus a total, I routinely will have them tested and wait, so that we can be sure that we don't need to do a total and we're not missing a CDH1 mutation. So absolutely. Or in some cases, I recently had a family that has a CTNNA1, 1A mutation, which is a very rare mutation. It's actually the first family that I've seen with that mutation. I know about it, but it's rare. But that was the causative agent for that family's gastric cancer. So the geneticists are so instrumental in helping us to make these decisions and offer the right operation. Dr. Yagi, I think you have a comment.
I remember more than 15 years ago, we had patients with family history, young patients with distal cancer, and we decided to perform subtotal gastrectomy. After some years, 2 of these 3 patients developed proximal gastric cancer. So at that time, we discussed a lot if we should do total or subtotal, but we had no data concerning about performing total gastrectomy. But I regret that we should do total gastrectomy at that time, even though we had no screening for genetical screening.
Yeah, it's very helpful. And I tell patients, patients are very upset that they have to consider total gastrectomy in these cases. But I tell them it's, in a way, they have to look at it as, a gift. I say that cautiously, because now they have information that can help them to make a decision about a risk factor that they have that really can take their life, and they can make a decision about it before something bad happens. So having that extra information, for most people, it's very helpful. For some people, it can be a burden. I have a lot of patients who have younger children and who ask me, when do I get the children tested? And that can be a difficult situation, as I'm sure you've all encountered, because young patients, 14, 15 years old, having that information one way or the other can be psychologically affecting. And for patients who don't know, sometimes the younger patients are just desperate to have the test because they need to know, and it bothers them that they are being recommended to wait until older ages. So these are complicated situations for sure. You're on mute.
How do you give the patients vitamin B12? I mean, cobalamin. You give orally, sublingual, or injection?
Yeah, we used to do injections, but recently now we're doing sublingual B12, and we found that patients are able to maintain B12 levels that are completely adequate with just slight modifications of sublingual B12. Much nicer than getting a shot. How about the rest of you?
We still do injections, but recently we saw patients with trying sublingual, but it was not working. I don't know why, but it was homocysteine very high, you know, so we came back to the injections.
Yeah, I still do injection. Yeah.
You still do injection? Yeah.
Me too.
Interesting. And also, just for the audience, we just want to point out that what we're talking about here is the germline CDH1 mutation, not somatic CDH1 mutations, because almost all gastric cancer, diffuse gastric cancers, by definition, practically will have somatic CDH1 mutations, so mutations in the tumor. But what we're talking about here is the germline mutations, just to make that clear to the audience for some of our younger audience members. There was one other comment. So again, I don't know how often you're seeing patients now that have the pathogenic CDH1 mutation without a family history, but how are you handling those patients?
I had no such a patient.
You're lucky. So yeah, it's been a common and difficult problem in the United States. So, but our paper, we try and define that risk a little bit. So if more genetic testing is being done in Brazil, which I'm sure it will at some point, then hopefully we'll be able to study this further and provide patients with more updated data to make good decisions. Yeah. So I see we've run over time a bit, and I apologize for that. Please.
It's so nice to be here talking about this. So there's no need to apologize. We are all enjoying.
Great. We could talk about this all night, but we probably have to wrap up too.
It's true. So Laura, how are we with our time? It's time to close. Then we can go to our final remarks with our invited surgeons.
I would like to hear the final considerations about all of our panelists, and then we can close because we are time off. It's 9:15 in Brazil, so I think it's time to say goodbye to all of them. So, starting Dr. Kuri, do you have any final considerations for our meeting?
First of all, I would like to thank you, Dr. Laura. Thank you, Professor Danton, and all the panelists. That's such a great team. And one consideration I want to make is that we have a Japanese guideline published on 2020. Saying that the splenic hilar lymph node number 10 has been deleted from the D2 lymph node resection. That is something very interesting because it's very difficult to remove this by lab. By robotic, I think it's more easy, but it's a interesting changing on the approach of the D2 resection for total gastrectomy. And thank you for all the panelists for sharing all of this, and Dr. Strong especially to be with us.
Thank you, Doctor. So, Dr. Danton, your final considerations.
Well, I will leave the time to the other panelists. I think I already talked too much tonight.
Dr. Yaji, your audio is muted.
Okay, sorry. I would like to thank the invitation. It was very nice to be here in this webinar. I'd like to thank to Dr. Strong thank you for the wonderful cases and the wonderful lecture, and also for the audience. I know that there were around 4,000 subscriptions, and but I have a last question. I'd like to know if Dr. Strong perform or something with peritoneal metastasis like HIPEC or intraperitoneal chemotherapy. Excuse me, I know that it's late, but it's an opportunity for us.
Yeah, yeah, I'm sure Dr. Hugo would be able to talk about this also. Currently, we're not offering HIPEC at Memorial Sloan Kettering. I was just speaking earlier today with two colleagues of mine, former MSK fellows who are in other institutions and do have open HIPEC trials. So there are several centers that are studying HIPEC for gastric cancer. And I think it is a very hot and important topic. We're currently not offering it, not under a clinical trial, but I think that's a topic for an entire other debate or series for one night.
Definitely.
There's a lot of data and it's a very controversial topic. But yeah, so that's the short answer. So
thank you.
I certainly would like to thank Laura for putting together this great this talk, and Danton Korea for inviting me and for really putting together a great panel. This was so much fun. It would have been nicer to be in Brazil, but this is probably the best thing that we can do now during COVID time. And it's really been a pleasure to meet all of you and to be part of this panel. And I thank the audience also for hanging in there with us so late at night. So thank you.
The pleasure is ours. We hope to see you in Brazil as soon as possible the next year, so we can talk personally. So, Dr. Rafael Araújo, do you have any considerations?
Yeah, I'd like to say that's a privilege for me. It's really big to stay here. Thank you, Danton, Victor, Laura, Osmar, Ana, and Antonio for holding this nice meeting. And thank you, Dr. Vivian Strong, because I used to be a research fellow at Memorial at the time, at the same time that Eduardo Vinuela. So I was there when the first meta-analysis showed up with your results about the lymphadenectomy. So, and now stay here and discuss with you. It's a true privilege, and thank you so much for your amazing presentation, as well as Victor. Thank you so much. So that was great. And again, thanks so much everybody for your attention and your patience to stay till late night here with us. It's a privilege for me. Thank you.
Thank you, Doctor. Dr. Victor Hugo da Fonseca, your final considerations.
Yes, I have a very few take-home messages. First of all, multidisciplinary management of gastric cancer is of utmost importance. We cannot forget that. Second of all, FLOT is the perioperative chemotherapy of choice still in the management of advanced gastric cancer. And we should start trying to test all the patients with the gastric cancer for MSI high. These are some of the takeaway messages that I would like to say. And again, I would like to express my gratitude. I would like to thank the panelists, Rafael, Danton, Dr. Osmar, and Laura for organizing and putting all this together. And of course, I would like to restate that it has been a pleasure to have Dr. Vivian Strong with us tonight, and trying to absorb as much as possible the experience that she has in her clinical practice. So thank you very much, everybody.
So it's that. Dr. Danton, do you have any other considerations for a final statement?
Yes, it's just to say my great thanks to Vivian and to all of you that took your time and instead of being with your families, you chose to be here with us to discussing this topic that I think all of us love, and it was a great learning experience, and this sharing it's all about it's all about what is medicine is about, actually. Medicine is about this, about sharing knowledge, about learning with each other to take better care of our patients, and this is a great way of doing it. And the only thing that I have to say is thank you for all of you.
Thank you all. Have a good night.
Thank you.
You too.
You too.
Bye-bye.
Thank you all.
Stay safe.
Goodbye.
Bye. Thank you.
Bye. Thank you.